Good morning, folks. We'll give it just a minute to see if anybody else signs on. I'm also in the process of updating our PowerPoint for today with some new data. If I don't get all of it in there, I'll finish putting it in there for Monday. I don't even know if we're going to get to this today, so. There's actually a new version of the MMPI, so I want to make sure y'all have the updated information about it.
I hope you're feeling okay.
I'm generally feeling okay. You will hear me cough and like see me blow my nose, but it's mostly my throat. Wednesday, the reason I had to cancel class, I don't think ever had to cancel class for being sick before, is because I opened my mouth and nothing came out. Like I've never had that happen before when I'm teaching. So yeah, there's no way y'all could have understood me. So I'm sure people weren't super sad, right, to get the day off, but thank you as usual for being understanding. And
Yeah, glad you're feeling better.
thank you. Yeah, I'm me too. Yeah, it's never fun, and it's especially not fun when you are, again, trying to just do what you can to teach the best I can for y'all. So I have my podcast microphone. I feel like I should be doing a podcast about true crime. Ironically, I actually bought this for, I'm in my church choir and we've been recording since we can't sing in person. And so I bought it for that, but it's been helping because it has much better sound quality. I don't typically need that. As you all know, I'm fairly loud typically, or loud enough at least. But for this purpose, it's been working really well. So and in just a minute I will yep, cool, I got everything updated. Nice. I'm just gonna save this and then I'll stick it on our Google Cloud so that I'll be able to use it with the captions, which should help too. So yeah, I thought I had everything copied over and it turned out, the formatting was totally messed up. So we'll see what happens now that it'll be in Google Slides if it's even worse. But hopefully not. All righty. So I also want to real quick just touch base on the syllabus and where we're at with things. So let me share screen with that real quick. Okay. So we got through intelligence and neuropsych. Woohoo! And now we're on to personality. Obviously we missed a day, but that's okay because I give this more time than it probably needs. So we're starting it today. Today we'll start talking about this type of stuff in general. And then we will go into more specific. So we'll probably start to get to the MMPI today, which is why I wanted to make sure that's there. We'll finish that Monday, and then we'll also start talking about projectives, which are fun. They're things like the Rorschach, the things you think of when you think of psychological assessment. And then you all will do brief personality assessments. Unfortunately, I can't have you take something like the MMPI because I don't have the site license for it, and it's pretty pricey. You have to pay for each booklet and then also pay to get it scored and then also pay to get the report back. So I don't want to make you all pay for that, but we will be able to do some shorter clinical and personality assessments. And then your next exam is the 8th, which is a Monday, so a week from Monday. And again, we can play it by ear, and if we feel like we're going to need that Monday to do this, we can always push that back a day. my goal Wednesday was actually to take you all to the computer lab and let you do SPSS again. So we will do that sometime in the next week when the most people are in class, basically. So that, you know, once you do get your data in, or you'll be able to work with it. I also have been sending comments back to people who have given me their IRBs. I know I have one sitting in my inbox I still need to give feedback on. Basically, let me know if you have questions. You know, think about tweaking it, turn it back into me, and I will let you know when you're good to collect data. Basically, again, I'm serving as your IRB. So you do need final approval from me to actually start collecting. And I'm glad to, again, take some time in the next week or so to talk about options for collecting online and things along those lines. So we can do that maybe next Friday, see how everything goes. Okay, so let me close the PowerPoint so I don't get confused, and I will screen share this new spiffy PowerPoint that I have updated. So I believe your book refers to these as clinical and personality applications. And that's because even though, geez, okay, so sometimes even though I'm better, I am still going to sound like I'm going through puberty. So just bear with me through the squeaking. And, you know, we'll do what we can, basically. But again, sound is coming out and fairly consistently. So that's a big advantage. Basically, Wednesday, I didn't talk to try to make this happen. But this morning I imagined going in and I was like, it's kind of consistent. But then I imagined like people trying to hear me in Roop, which doesn't have the best acoustics. And I was like, they're just going to get more out of it if I do it remotely and they, you know, can hear me a little better. I don't know. I just feel like I'm either on NPR or on like a SNL sketch about NPR with this microphone. It cracks me up. Okay, so there are basically these things will be used for research, but the most common use for personality assessments is actually in clinical settings. So particularly right at the beginning, when you first get somebody in, you might take some time to have them complete some of these assessments we're going to talk about to help you figure out what's going on with them and the best ways to help them. And so you will often start, and in fact, you should start with a clinical interview. Basically, if you're having someone come in for any kind of assessment, neuropsychological, personality, or just an initial assessment before they begin therapy, you need to start with a clinical interview. So in this, you collect detailed information about the client's life and circumstances. And we'll talk more after the next exam about like how we actually diagnose people, and that'll be incorporated. But typically we're going to start with what's called an unstructured interview, where we'll just ask the client the really open-ended things like, tell me what brought you in today. You want to tell them about interviews? I bet you're pretty good at them. Little Simba's here. He likes to hide. This is how I started all my interviews when I was seeing clients, just really open-ended. And depending on the client, and sometimes depending on the nature of their issue, this could be a one-sentence answer. I've been feeling depressed. Or, you know, I had a client who had anxiety and narcissistic personality disorder, and he talked for like, I want to say a half hour about just this question. And he kind of filled in some of the other questions I would ask anyway in doing so. But, you know, that gives you a lot of information about this person and how they're functioning, right? Other open-ended things like, what was it like growing up in your family? You can kind of probe for, you know, abuse or really positive things without having to explicitly say that, right? Well, my husband's going downstairs, so there might be food. So Simba's also going to go downstairs. I know there won't be food, but he always thinks there might be food. So And then, do you feel that people are there for you when you need them? Thinking about their social support system, who can they draw on as they go into this? There are also structured interviews that get at some of the same information. So the structured clinical interview for the DSM, there's now a DSM-5 one. This is called the SCID. Not everyone gives this for a bunch of reasons. So your typical intake interview is anywhere from an hour to an hour and a half. And then the SCID takes another half hour. And if you're in an insurance-based practice, it could be the case that insurance will only pay for an hour of assessment. And that doesn't count any time you're going to spend analyzing the data, writing the report, right? So you might choose not to do the structured interview because of that. When I was working on my residency, which was in a whole bunch of different scenarios, but the one where I had to deal with insurance was at the medical college, their outpatient clinic. And I don't know if this was just Georgia law or the way insurance operated there or what, but by the end of my first session, which was typically an hour, I had to have a diagnosis for them and kind of know everything else about their background. So, you know, I didn't have time to sit down and do a full SCID, and I had to do sort of this abbreviated interview. When I was in my training clinic in grad school, it was at that time free. I think now they charge people $5 a session. It was, we could take as much time as we needed. We could do an hour and a half or 2 hours for the initial interview and then do the SCID at another session. And actually every client also took the MMPI that we'll talk about later today. So, you know, when you're in that sort of more training-based or research-based session or environment, then this is more typical. So, you know, again, as much as we would love to do this for every client, it's just not always possible. So sometime within the next week or so, you all will also give each other a short version of the SCID and do an intake interview with your partner that you did the neuropsych assessments on. So that's often really fun. And you can decide if you want to be yourself or if you want to like come up with a character. So the SCID, the very first question you ask after the screener is, in the past 2 months, have you been a period of time where you were feeling depressed or down most of the day, nearly every day? And I actually didn't read that off the slide. I still have that memorized from giving it to so many people. And then it basically just works down the symptoms in the Diagnostic and Statistical Manual, the DSM, and asks a question about each symptom. So you're literally just checking whether they endorse each symptom, yes or no. And then you can get structured interviews that are even more specific. So for example, in my subfield, there's one called the Eating Disorders Questionnaire that is looking at symptoms of eating disorders. At the VA, again, the VA is a different system, right? VA patients are under sort of VA insurance, right? So we don't have as much of like time constraints or things like that. So we were able to sort of take a step back and, you know, take our time to do stuff like this and make sure we were doing things right, which is nice. So the CAPS, the Clinician Administered Ptsd scale, asks specifically about the symptoms of PTSD. So you ask about what we call their criterion A event, what was the trauma? And then you ask, again, kind of go down the symptoms of PTSD. Have you ever had unwanted memories of, you know, and you'd fill in the event they told you, the car accident, the sexual assault, the combat trauma, or they like, what do you remember? You ask them how frequently they've had them. And so I like the CAPS because every symptom gets a yes, no. And I think there's actually a scale of like how severe it is. And then there's frequency. So how often are they having it? And intensity, essentially like how much is it affecting your life? So frequency, how often have you had these memories in the past month or week? And then intensity, a series of follow-up questions. How much distress or discomfort did the memories cause you? Were you able to put them out of your mind and think about something else? How hard was it to do that? And how much did they interfere with your life? So you get a really nice picture of not only the person's symptoms, but how those symptoms are affecting their life. Yeah, I have to say, this is just like a side note, since we're talking about clinical things, that I decided not to be a clinician because I'm really bad at compartmentalizing. I would like wake up in the middle of the night worried about my clients. I think there are a couple circumstances under which I could be a clinician. One would be to be someone who does mostly assessments, because you do kind of have that disconnect there. And the other would actually be to work at the VA. And the reason for that is because they have the ability to do things like this, and then they're using empirically supported therapies to treat trauma. And these therapies work really well and really efficiently in a way that like therapies for eating disorders don't always. So yeah, I found that really rewarding. And were I to ever do that again, this is what I would want to do. I'd want to work at a VA in their PTSD unit. Sometimes in clinical interviews, you'll include a formal, what they call mental status exam. And in fact, sometimes the formal version of these will end up in a neuropsych eval that we've been talking about. So there's like the 3MS or the MMSE, which are basically like screeners for a whole bunch of other things, but also get at mental status. So you ask things like, you know, what's today's state? What city and state are we in? What building are we in? What floor? You give them a series of words to remember. You have them like count forwards and backwards. You have them draw something and follow instructions and point to things so that, you know, they know naming. So that is, again, often done when there's any kind of question about the person's cognitive abilities, their memory, things along those lines. In a typical clinical setting where someone's coming in for depression, anxiety, what have you, it's much more likely you just sort of assess this by observing. So were they able to find your office? Did they show up on time? What is their ability to communicate? Right? So can they like describe what's going on with themselves? How put together are they? Right? So for some of my depressed clients, they would come in looking like they hadn't showered in a week, and often because they hadn't, right? Because when you're severely depressed, it can actually be really overwhelming to even do basic skills, which is a little mind-boggling to us, right? Like that doesn't, like, how can you not have the energy to shower? But that's what happens for these folks. Other things like their rate of speech, whether they're able to make eye contact, whether they sit quietly or are constantly kind of agitated and moving, all those can play into the mental status exam informally. The limitations of interviews to get at these sort of clinical and personality things is that, you know, they can lack some validity because, you know, the interviewer is choosing the questions. The interviewer decides, you know, what we're looking at, what we're not. And it can really affect who is, you know, what information you're getting from that person. And then the interviewer can be biased. So I just laugh every time, even though I shouldn't laugh because this was horrible. There was a psychiatrist I knew when I was on my placement, my 4th year in grad school, who believed that just major depressive disorder didn't exist. He thought that everyone who came in with depression was bipolar. They just didn't have a manic episode yet. This is not true, right? But because of that, he never diagnosed bipolar disorder or depression. He would always diagnose everyone with bipolar disorder. Other interview bias can be not as problematic. So for example, because I studied eating disorders, I would always ask people about their eating habits and probe a little more, not to misdiagnose them, but to see if they were like using food to cope, for example. And so that could come into play. It can also lack reliability because people respond differently to different interviewers, right? So there are people who prefer interviewers of the same race or the same gender as they are. And if they have someone who's not that, right, might give kind of a different degree of opening up about what's going on with them. And also it can depend on like the stage of their life. This week, I just finished Leaving Neverland, which is a couple years old, but it's about two of the boys, now men, who were abused by Michael Jackson. And like, it took them years and years and years to be able to like process what happened to them as abuse, because of like the grooming that goes on with child sexual abuse. And so, you know, it's not that they were purposely trying to lie per se. It was just like they had to be at the right place to discuss what happened to them as abuse. So like one of them, Wade Robeson, talked about he'd been seeing a therapist, but just never talked about this. And then like something clicked for him and he went in and like actually mentioned it. And the therapist was like, this is a big deal. We should be discussing this. So that can happen where clients don't have insight and something, you know, again, maybe just not at the right time in their lives. Give you another example. I had a National Guardsman I saw while I was at the VA. We had an agreement because there was an Army base in the area. So we would actually like flip-flop some services. So I was taking active duty Guardsman, and he had PTSD, but he also was going to get redeployed. And he basically said, look, my symptoms of my PTSD are what keep me alive over there, right? The hypervigilance, the always being on my guard. And I had to agree with him. I had to say, yeah, I don't feel ethically correct in taking these away from you right now. So I just encouraged him, like when he got back, when he was finally done, to make sure he came back and got therapy. And I hope he did. I don't know, because I came here. But, you know, there are just times where it's just not right for therapy. All right, so the next thing we're going to talk about is personality inventories, and I'm going to take a little nose blow break, so give me a sec. That's the other reason I didn't want to come in today, is on the off chance that I could somehow give this to you all through 2 masks. Didn't want to risk that. So personality inventories are designed to measure broad personality characteristics. And so even though they're called personality inventories, they really get at a lot more things than just personality. So they focus on behaviors, beliefs, feelings. A lot of what's on, again, what we're calling personality inventories are actually symptoms of various psychological disorders. These are usually based on self-reported responses. And obviously they're in contrast to like BuzzFeed quizzes or, you know, this comic I've always loved, because it's like, what color are you? And it's like, your favorite color is red, so you are red, right? A lot more validity, a lot more reliability, a lot of thought goes into designing these, which I'll show. I'm going to use the MMPI as like our main example, just because that's what I was the most trained on. But a lot of good science goes into this, and you could get a lot of information from that one instrument as a result. All right, so the original MMPI, and I believe also the MMPI-2, were over 500 self-statements. You get them on, and I'll bring this stuff in on Monday. Sorry, I'm not able to show you now, but I do have an original MMPI, an MMPI-2, an MMPI-RF, and an MMPI-3 that I can show you all of those. And so it's basically like a standardized test. Like you get a bubble sheet and you respond to each item, either true of me or false of me. And so, or if you leave it blank, that's rated as cannot say. And the reason that's then rated as cannot say is because the very original version of the MMPI was kind of like the Wisconsin card sort we talked about, where like they were given cards with the statements on them, and then they sorted those into piles that were like true, false, cannot say. Now it's pretty rare to get a lot of cannot says, especially if you set this up correctly. If you tell them, hey, this is going to give me a lot of good information about you, so please just take this seriously and answer things honestly. There are a lot of scenarios where people won't do that for various reasons. So for example, if you give an MMPI during a custody hearing, right? People want to make themselves look really good so that they get custody, right? And if they don't, that's almost problematic, right? In correctional settings or legal settings, right? Someone might try to look worse than they are to try to get like a not guilty by reason of insanity. One of my favorite stories about this is I took my psych in the law class with Chet Graham, who's one of the big names in the MMPI research. And he told us about one time when he gave the MMPI to an inmate, and the inmate just took the bubble form and wrote across it, "I am not crazy." And he was like, that's nice, but that doesn't give me any information on which I can like actually assert that, right? So stuff like that can happen. And so for that reason, we have what are called the validity scales. And these assess a whole host of things like careless responding, so just not paying attention, all the way up to lying. And the lying can go in either direction. There's like fake good, trying to make yourself look better than you are. And then there's like fake bad, trying to make yourself look worse than you are. And so, for example, one of the old items was, I read the newspaper cover to cover every day. And no one does, right? No one reads all the classifieds and all that stuff. So if people are endorsing that and items like it, there's probably faking good, right? Then there are items that even people with like very severe psychopathology don't endorse. And those are on the faking bad scale. There are also these clinical scales that assess symptoms of various disorders. And there are some personality traits like introversion. New versions of the MMPI also include actual measures of personality, including the Big Five, which is like the most commonly accepted personality theory right now. All right, I'm gonna try some gum, that helps. Each scale is on the T-score scale that we talked about previously. So being a 50, standard deviation, and now I'm blanking on whether it's 5 or 10. You can go back in your notes and see. And so scores of 65 and above are interpreted. Okay. So here are the validity scales. And at the time these were invented, this was a big deal because nobody had ways to try to suss this out, right? So the L scale or the lie scale measures attempts to fake good. Now, I do have to say, these are the initial ones. When we get to talking about the MMPI 3, which will probably happen Monday, although we'll get to some of it today, what you'll see is that there's a lot more validity scales now, and they're a lot more precise. The K scale measures defensiveness, which a lot of people have in any clinical setting. And then the F scale measures that fake bad, or making yourself look worse than you are. And sometimes this is trying to malinger, trying to lie. And sometimes this is just a cry for help. I mean, like, please, please, please let me have therapy because I'm so bad off. Hi, bud. Yes, you're right in the way, but I love you. All right. So these are the original clinical scales. Again, as we go through, you'll see that these have changed. But they use fun old terminology like hypochondriasis for physical complaints. The implication is that these are psychologically driven physical complaints. Depression, pretty straightforward. Hang on just a sec. Try that. Okay. Hysteria. This as it measures immaturity, it kind of gets at some of the same stuff as hypochondriasis, honestly. If one's elevated, the other one typically is on the MMPI and the MMPI-2. Psychopathic deviant was supposed to measure people with like antisocial personality disorder, but it really tends to measure more of like conflict with authority or problems within your family. There was a measure of masculinity, femininity, that were very much stereotypical masculine or feminine interests, including things like the first item on the MMPI used to be, I enjoy reading mechanics magazines, which go on the masculinity side of that. Paranoia, suspicion, hostility. Psychesthesia is an old term that is psychasthenia, sorry. It's an old term that means anxiety. Schizophrenia. If you go high on this, it doesn't necessarily mean you have full schizophrenia with hallucinations, etc. It could just be feeling withdrawn or alienated. Hypermania is that elevated mood or high energy from bipolar disorder. And then social introversion is shyness. This is a little bit of what a profile looks like. This is a textbook sort of dumbed down version. And here you could see these are the validity scales. Everything's under 65. This person's good to go. They're telling the truth. But they're high on several scales, right? So high on both of those. Oops, bud. Sorry, cat paw. They're high on both of those like physical attribute ones. Their highest score is depression, so it's definitely something we want to look at. And then they're also peaking on that anxiety related scale, right? Simba, you also somehow turned my mouse into this nifty thing, which is okay. So the MMPI was developed using a technique called empirical keying, which is bizarre in some ways for people who have never heard of it, and honestly for people who've heard of it. So what you do is empirical keying, and usually I'd write this on the board, so I'll just type it in the chat. The first thing you're going to do is gather lots of items that might measure the things you want to measure. And you're just going to have a whole bunch of people take them. And in particular, you want to find groups already diagnosed, say, with that disorder. So like for scale 2, you want to find people who are diagnosed with depression. And you want to also find groups not diagnosed with that disorder. You have them take the items, and then basically the items that the depressed people endorse, but the quote unquote normal people don't, those become your items on your depression scale. Then what you do is you give it to a new sample that's mixed of people with and without depression to see if it actually helps discriminate between those groups. If it does, great, or good to go. If not, then you might need to tweak it a little bit. Okay. So because Empirical Keying follows this path, in theory, it doesn't matter what the items say, right? Just that they differentiate between these groups. And they would do the same thing for each scale, right? Right, mute again, sorry. One of the original designers of the MMPI actually would proudly state he had never read all the items because he believed so much in empirical keying. However, there were some problems with the original sample that draws the validity of the empirical keying for this particular scale into question. First off, it was created in Minnesota in the 1920s, 1930s, I think, and only used people from Minnesota. Thinking out loud, either unmuting yourselves or typing in the chat, what might be different about people from Minnesota than the rest of the country?
I guess just probably just like area or cultural, well, social norms, and I guess just economics, and I guess a whole host of other different types of things that go on, particularly for that area that wouldn't necessarily be the case for any other area.
Mm-hmm.
Yeah, it's not as diverse either. Like, it's particularly dominated by like whites. I feel like it's not as diverse as a place like here. Exactly.
Yeah, you guys are both spot on. So because of the area itself, it isn't very diverse. It's better now. Actually, like strangely, Minneapolis has like the largest population of like Rwandan immigrants, which is really interesting. But at that time, it was mostly white farmers who were of Scandinavian descent. So that's a problem. The other problem is they're, groups of the thing they were trying to test, like their groups of depression, et cetera, were good. They were actually people who were hospitalized for these disorders or seeking treatment for these disorders. Their contrasting sample, however, the quote unquote normal people, were relatives of people who were visiting their loved ones in the hospital. What issues could arise there? What do we know about genetics and psychological disorders?
I mean, they go hand in hand. I feel like, I think someone with schizophrenia, like someone who has like a close relative, like a mom or an aunt or something like that with schizophrenia, they have a higher likelihood of getting that disorder than
Exactly. You guys are spot on. Yeah. So like they didn't take that into account, that like these people might not have needed to be hospitalized with this disorder, but they still could have, oops, sorry, Simba, symptoms. And they still could have, the propensity for that disorder. So it's not a clean sample. So it was, these things were recognized, but sadly, Again, I think the original MMPI came out in the 30s. Sadly, these things were not really recognized and fixed until the 80s. So there was 50 years based on this not so great sample. So in the 80s, they revised it and it became the MMPI 2. And this is what I originally learned to give. So when I was in grad school in the early 2000s, that's still what we were giving. And so they did things like new norms for the sample, much more representative. They did things like look at item content, which again, the original guy was like, who cares? But the MMPI is actually used in some scenarios for employment decisions. So you can't ask illegal questions, right? So they had to go through and look for those. So for example, if you want to be a police officer or a firefighter, it's often true that you will be given this, for example. And yeah, just a bigger formative sample as well, revising items, updating items, modernizing language. And then at the end of the time I was in grad school, so 2008, 2009. So again, we had gone 50 years for the first revision, right? And we went from the late 80s to the late aughts for the second revision, so about 20 years, okay. But we got the MMPI 2RF. And this was the restructured form, basically. And so I was really lucky in that I went to grad school at Kent State, which has some of the top researchers in the area of the MMPI in the country, which I had no idea. I didn't even know what the MMPI was before I went to grad school. It just happened to be where my advisor, who had similar interests to me, was. But so I actually got one of the first, I think maybe the first workshop in the country about the RF, because Yossi, one of our professors, actually was one of the co-authors of the RF. So very cool stuff. With the RF, they made a lot of updates and revisions. I'm trying to remember if I have a slide about this. So let me see. Here we go. I do have slides about the MMPI too. I kind of said all this, I think. Oh, they added some new validity scales. And in the 80s, they also came up with the MMPI A, which is for adolescents. So if you want to give this to a teenager, you can now. Before you weren't able to. And the new validity scales they added were measures of consistency. So the VRIN, or variable response inconsistency scale, gets at, are you answering similar questions the same way? So it'll have like kind of the same question, just worded slightly differently at different points in the MMPI, and then look to see if you're answering those the same way. If not, it's a measure, again, like 1 or 2, no big deal. But if you're doing that consistently, it's a measure of you just not paying attention, right? So the VRIN is to catch people who are just randomly filling in bubbles. The TRIN, or true response inconsistency scale, is basically to see if you're just answering true to everything. And it's kind of fun. When I was learning about this, again, because I had MMPI researchers as my professors, they actually showed us what it looks like if you just go through the MMPI and just fill out true for everything. And like the profile looks so messed up, right, as you would expect. So the TRIN can also be scored the opposite direction if you're answering all false as well. So again, just getting at, is the person paying attention when they're taking it? I mentioned much better norms, a bit better educated and more affluent. Again, because a lot of times the places that collect this data are in universities. And even if they're going beyond their students, you're in a university town, right, where you're more likely to have more educated people. EMPI 2 added some new content scales to measure different things like family problems or attitudes that interfere with work performance, health concerns, or type A personality, being really uptight. And then the RF, hey, I was right, 2008. The RF was a more radical departure than the two. So the RF, what Yossi and Akateligan and their students have been doing was looking at the data from the MMPI-2 for years and trying to figure out inconsistencies and trying to figure out issues with scoring. And they did what's called factor analysis, where you throw all the items of your scale into this statistical analysis. And the statistics tell you these are the items that sort of should go together, should be a scale. And when they did that, what they found is that all the clinical scales had the kind of the same items on them. And when you pulled those items out and made them their own scale, it was really just a scale of demoralization. It makes sense. If you are experiencing psychopathology, you're going to feel kind of blah. You're going to feel kind of down. You're going to feel overwhelmed, right? And so on the MMPI-2RF, they made this its own scale called the RCD for demoralization. And then they took the clinical scales and when they pulled out that demoralization, they found there were like more pure measures of the individual psychopathologies. So made it cleaner, made it more accurate. The MMPI-2RF was shorter as well. So now we're under 400 items instead of over 500. And then what I really liked is they made it so like none of the clinical scales shared items and none of the content scales shared items. So you're not getting that overlapping, right? That makes interpretation messy. They also introduced this concept of higher order scales. There are 3 of them. So essentially, are you having dysfunctions in terms of you're internalizing everything, you're taking it into yourself, you're feeling emotional, you're blaming yourself for everything? Are you having thought dysfunction, seeing things, hearing things, thinking things that aren't true? Or are you having behavioral or externalizing dysfunction, where you're kind of behaviorally taking stuff out on other people, whether that's through drinking and driving or anger management or things along those lines? So that gives you an overall picture of what's going on with that person. Here are those restructured scales. And so again, we've got that demoralization scale. And now these become much cleaner, right? So now instead of hypochondriasis or like faking illness, right? This is a list of somatic complaints about your body. The scale of depression became a scale of low positive emotionality, which is really interesting. And a lot of research is now pointing to an inability or diminished ability to experience positive emotions as one of the key symptoms in depression. It's really interesting. R3 now became cynicism instead of hysteria. RC4 became much cleaner and it's now antisocial behavior instead of all that other stuff. The paranoia scale became ideas of persecution, so much more specific. The anxiety scale became dysfunctional negative emotions. So not that negative emotions in general are dysfunctional, but at this point they get to the point where they overwhelm your life and make it difficult. The schizophrenia scale became aberrant experiences. And we've still got some mania going on there. Alrighty, I think I'll stop there because I'm going to start getting into the MMPI-3. And we'll start with that on Monday. But I have some really cool information on that. I was able to take a workshop on that last year, actually with Yossi, which was cool. So I hadn't had him since grad school and I got to spend like 8 hours learning from him. So I will give you all the updated info about the MMPI-3 on Monday, and I'll bring in all my MMPIs so you can see the various versions. Thanks for hanging in with me. And take care of yourselves, and I will see you in person on Monday. Bye, y'all.
Have a good one.
You too.